Hello, my name is John Triedman. I am an associate professor of pediatrics at Harvard Medical School and a member of the Department of Cardiology at Children's Hospital in Boston. My talk for the Journal of AFib today is entitled Reducing Risks and Improving Outcomes in Complex Congenital Heart Ablations. In general, it's important for us to follow a sequence of steps in understanding and approaching complex arrhythmias. We need to understand the underlying substrate of the arrhythmia. We need to obtain adequate access to the myocardium, and we need to be able to modify the tissue in a way which both terminates the arrhythmia and prevents it from recurring. In addition to, we can break down these steps further, and thinking of the rhythm substrate, we need to both understand general principles underlying the particular disease process and anatomy of the patient, but also we need to have good ability for us to determine patient-specific anatomy. And with respect to ablation, we both need good techniques to modify the tissue, but we also need to be able to assess the efficacy of this intervention after we've made our ablation attempts. We can apply this rubric both to simple types of arrhythmia, such as SVT in the normal heart, where we can apply a number of standard and time-tested and quite simple technologies to achieve successful ablation. And also to complex atrial and ventricular arrhythmias of the type that we see in patients with complex congenital heart disease. We may find ourselves needing electroanatomical mapping, the assistance of intracardiac echo, special techniques to achieve transeptal access, high-powered irrigated ablation techniques, and lesion imaging in order to effectively manage these patients. When we look at the development of technology that has taken place over the last 10 to 15 years, it's easy to identify several specific innovations and new products which have helped us to decipher these complex problems. Dealing first with the phenomenon of very complex arrhythmia anatomy in these patients, myself and other practitioners in the field were extremely quick to adopt the use of electroanatomical mapping systems, and that resulted in significant improvement in our outcomes. We did not have perfect outcomes, though, and one thing that we proceeded then was that we needed to create bigger and more transmural ablation lesions. And with that, we began to institute adoption of irrigated and high-power ablation systems. At present, we are learning how to refine our anatomical targeting of ablation, in part by using multimodal image fusion and real-time imaging. And in the future, we hope to be able to visualize our effective lesions as we're making them, perhaps by lesion imaging using MR or other techniques. Going back to the beginning of that sequence that I just outlined, it's now some time since we began to have access to electroanatomical mapping. On the left, you see a fluoro image denoting a very complex atrial anatomy with significant surgical intraatrial baffling performed on a patient with congenital heart disease. And the anatomy of the atrium is quite cryptic using fluoroscopy, but it's possible using electroanatomical techniques to define the specific chambers of the atrium and also to superimpose on them the activation sequence of the arrhythmia, which not only indicates to us the underlying surgical anatomy, but also allows us to target very easily the relationship of the desired ablation zone in relation to the surgical atriotomy scar. Additionally, we have become quite we routinely use irrigated radiofrequency catheter ablation in these patients now because we found that the outcomes with that technique are significantly better than standard RF ablation. This is the results of a multi-center study from Europe published some years ago, just looking at the effect of irrigated RF ablation on these specific congenital heart patients with atrial tachycardias, and they demonstrated both a high acute success rate and, importantly, a relatively low recurrence rate, a problem which has been quite difficult to address in this population of patients. So those two innovations fall at the top of that sequence, and what we need to do in the future is move into the area where we can further refine our targeting and see what we're doing with the ablation catheter as we do it. And in congenital heart arrhythmia ablation, we take a lot of our lead from the practice and innovation which has developed around the ablation of atrial fibrillation. In atrial fibrillation, obviously, volume imaging and its fusion to allow electroanatomical mapping and ablation of the left atrium has been an enormously useful approach in dealing with pulmonary venous antral ablation. One thing that makes that an advantage for working in the left atrium is the rather asymmetrical and very critical anatomy of the left atrium, which more or less determines the desired location of the ablation lesions. This is an example of an image fusion in a patient with complex congenital heart disease. In gray, underlying you see what we would call the Fontan pathway, or the enlarged right atrium, which has been directly anastomosed to the proximal pulmonary arteries. And we have registered with that an electroanatomical map. And you'll notice that it gives us quite a nice picture of where this particular arrhythmia circuit was and its relationship to some scarring. But if you look at the shape of that, one thing you'll notice is that it's a relatively featureless chamber, and I've overlaid a little picture of a cantaloupe on it. What we're really interested is more the writing on it that you saw as the scar, the features that are not necessarily obvious by the shape of the chamber, as they might be important in atrial fibrillation, but some other aspects of the substrate which we would like to be able to visualize in order to direct our ablation. This is an electroanatomic map of a patient with similar anatomy of the right atrium, looking from the side with the IVC at the bottom. And what we see here is a map of a very typical reentrant tachycardia circuit in one of these Fontan patients, and it indicates that the distribution of scarring on the right atrium is in fact the critical factor that determines the ablation targets in these procedures. So what we would like to be able to do is non-invasively assess the scar. We know that both discrete and diffuse areas of scarring constitute the functional anatomy of our arrhythmia circuit, and also define the targets for our ablation. And if we could measure and examine those features precisely in a functional image of the scar, it would significantly improve our ability to do these ablations. This is a case example of this type of approach, a 23-year-old young man with a single ventricle who has also undergone this Fontan procedure. You'll notice that while the intracardiac anatomy, in particular the ventricular chambers and pulmonary arterial and venous anatomy, are gorgeously outlined here, the right atrium again is a rather featureless oval shape, and we need to get more information about what the functional anatomy of that right atrium is in order to guide our ablation. So one thing that we can do is we can begin to experiment by assigning scar on the basis of electrogram amplitude. And here we're looking at different thresholds, 50 microvolts, 100, 250, and 500. It turns out that based on studies of patients with congenital heart disease and in the practice in the field in general, 100 microvolts is generally accepted as a reasonable level to set for scar threshold in terms of finding the areas of scar that functionally constrain arrhythmia circuits. So I've taken 100 microvolt threshold of scarring on this patient, and now I've superimposed on our original pictures of the right atrium the areas of scar in AP and lateral view. I also here add in the AP view you can see the area of the tricuspid annulus, which is oversewn by a patch. This is determined in this case by intracardiac echo, which I'll come back to a little bit later in this talk. But first I want to talk about defining discrete areas of scar. In particular, I'd like to identify the atriotomy in this atrium. And what we're doing is, as we map, we are assigning blue dots to the areas that show double potentials and using them to draw a line which corresponds to that area of specific conduction block. And we can go ahead and draw this in on our map now. And you see now we have a fairly well-defined geography with which to work on. And when we do our activation mapping now, we can tell that we have at first a periannular flutter, and we can actually see a route to interrupt that by placing ablation lesions between the edge of the tricuspid annulus and the scar. Now, observant watchers will also notice that there's a second potential circuit there, and in fact we did identify a second slower tachycardia which utilized this lateral corridor, which you see is still open, and by continuing our ablation lesions out to lateral scar, we were able to completely cure this particular patient's atrial arrhythmia. We have been using intracardiac echo to assist in atrial tachycardia ablation in congenital heart patients. This has been recently published from a European group in a small number of patients where they identified relevant structures, used ICE to assist in the performance of transbaffle punctures and also monitoring tissue contact, and we have found that all of these aspects of the procedure are aided by the use of ICE. Another case example, a 47-year-old with complex heterotaxy had a very unusual intraatrial cavo-cable baffle with a fenestration that was partially closed, and he was having recurrent intraatrial tachycardia requiring multiple cardioversions over a several-month period. This is an angiogram of this very interesting intraatrial connection. You can see dye going across a small fenestration in that baffle into the pulmonary venous atrium, and that's where we need to get to in order both to map the atrium and to ultimately perform our ablation. Here we are looking from within the baffle using intracardiac echo, and the bright line at the top is in fact the wall of the baffle, and you see the pulmonary venous atrium behind it with a small jet of blood going across. And you can also see coming within and without the field of view the tip of our transeptal catheter, which we then passed across into the pulmonary venous atrium. Once we were in the pulmonary venous atrium, we were able to make maps of two flutters, one of which had clockwise rotation around the right-sided AV valve annulus and the other counterclockwise. So we inferred that this was actually a very unusual form of typical atrial flutter in this complex heart. And when we went to ablate, we put our catheter in the cavo-tricuspid isthmus now identified by the intracardiac echo, and you can see the termination of flutter right there. And importantly, you can see both the leaflets of the AV valve and the position of the catheter by the baffle wall, where we finally completed that line and terminated our arrhythmia. Another aspect of intracardiac echo, which has been very useful in these patients, is the ascertainment of surface contact. And again, we have on the main part of the slide here a complex atrium with obviously many areas of scar and mapped points. And you see that we are attempting at the bottom of the map to place ablation lesions in relation to the tricuspid valve in the lower part of an atriotomy scar. And we were quite certain that this was an area which we needed to approach with ablation, but couldn't seem to affect ablation, even though we were recording reasonable electrograms there. And when we looked in the upper right, you can see with our intracardiac echo, we realized only then that we were almost 2 centimeters away from the endocardial surface. And placing a sheath to further direct our catheter allowed us to have much better contact with the atrium, here demonstrated by ICE and also by a larger electrogram. And we also had immediate termination of the arrhythmia once we were actually applying these more effective lesions. What's going to happen in the future? Well, clearly there are going to be better non-invasive ways to determine the substrate of the atrial myocardium and manipulate catheters. Here you see in recent issue of Circulation, Arrhythmia and Electrophysiology, a demonstration of an MR visualized EP catheter and real-time MRI, allowing that to be guided in the atrium. In addition to some of the obvious anatomical advantages that might bring to these complex patients, I think even more important is the possibility that we will be able to visualize in real time or near real time atrial injury caused by thermal ablation, as here demonstrated from Niles et al. In the IEEE journals, looking at work done by the group in Utah on mapping out scar in the left atrium in response to atrial fibrillation ablation. So in summary, in order to approve ablation in these complex adult congenital patients, we need to remember that anatomy is everything. First, we need to image the native anatomy, and in the future we're going to need to image the tissue substrate and the effects of our interventions. In pediatric and congenital EP, it's always our job to repurpose and adapt novel technologies, mostly derived from the progress of AFib ablation, to drive innovation in our field. Measurement of safety and efficacy will ultimately catch up to where we are now, but I would imagine that by the time it does, the field will be moving on to new challenges. Thank you very much for your attention. So you may need to adjust